I'm Dan Shrey. I'm one of the epilepsy specialists at Children's Hospital, Orange County. I have a special place in my heart for infantile spasms. I've done a good bit of research on it over the last several years. And we are continuing to do a lot of work with it, as you will see in the second part of my talk today. I also am currently the leader of the Infantile Spasms Research Group, which is part of the Pediatric Epilepsy Research Consortium, which is a consortium of 20, or our group, it consists of about 20 different level 4 epilepsy centers, pediatric epilepsy centers across the United States. And the PERC, the kind of parent group, is many more than that, probably in the order of 35 to 40 at this time. But you'll hear more about that in the second half. What I was going to talk about in the first half of our time together is just a kind of an overview of infantile spasms or epileptic spasms, and we'll talk about the difference between those things. This is just meant to be a very broad strokes review of it. There's obviously a lot more detail than this, but kind of sets the stage for us telling you a little bit about the exciting work we're doing through PERC in the second half of the talk. So the first part is probably about 25 minutes long, and then at the end we'll kind of pause for questions. If you do have questions during the talk, by all means, send them via the chat, or you could wait till the end and we can go over things, whatever you prefer. So, and first, just some disclosures. I do a little bit of research, and so I'm funded by a few different agencies, including NIH and a couple foundations, as well as the Children's Hospital of Orange County. And then I have done some work in the last few years with different pharmaceutical companies that are interested in developing treatments for infantile spasms. So, so that is that. None of that really has any relevance to this talk because it is based on the current literature. So some people get a little confused because in terms of the terminology we use, we've historically called a type of seizure infantile spasms, but more recently we've switched to using the phrase epileptic spasms. So just to clarify what it is, so an epileptic spasm is a type of seizure, and when it happens in an infant, we call it infantile spasms, okay? So there are older kids that can also have epileptic spasms, and so those would not have infantile spasms, like if it's a 4 or a 5-year-old, or even an adult. So that's really the difference. The seizure type can affect people of all different ages, and when it happens in infants, we call it infantile spasms. So the definition that we use when we talk about spasms are that they usually occur as clusters of jerking movements that last 10 to 20 minutes or so, sometimes longer, sometimes less long, characterized by head or truncal flexion and extension/flexion of the arms or legs, each lasting seconds. They have a crescendo and decrescendo pattern, and what that means is that within a given cluster, they usually start more subtly, they become more significant or bigger in the movements, and then they kind of taper down as the cluster ends. They can also happen as single jerks. So basically, these are the rules, and all the rules can be broken, is the bottom line here. Usually, though, these are the characteristics we use to help differentiate between spasms and other unusual movements that affect kids in the first year of life. So they more frequently happen when a kid's waking up from a nap or falling asleep or after feeding. Sometimes they can be triggered by a startle. Majority of these spasms are what we call flexor, which means the arms come in like this and the neck and trunk move forward, as opposed to extensor, which is when the neck and trunk extends and the arms move out. And probably the majority have some mixed components. So a lot of times you'll see extension of the arms and flexion of the neck and trunk. Sometimes you'll see flexion of the arms and extension of the neck and trunk. So, and kids, to make it even more complicated, many kids have more than one type of appearance of their spasms. So, and even within the cluster, you can see that they change a little bit as the cluster progresses. Most of the time, we do see that spasms happen with symmetric movements, but they can be asymmetric, especially in cases where there's a particular part of the brain that's generating the seizure, like a focal lesion inside the brain. And then also, over time, as the spasms progress over weeks to months, they can change in appearance too. The way the kid is positioned is really important for diagnosing spasms, because there are other things that look like spasms, like drop attacks, for instance. And so if a kid is sitting up and leaning forward and they fall forward, it's really impossible for just by watching them with your eyes to know if that is a drop or if it's a spasm, which is a muscle contraction. So I always talk with my parents when we have them on EEG to, if they see the kids start to have a cluster of events, lean them back so that they're resting backwards, like on an incline. And then if they'll have a spasm, they'll crunch up. If it's a drop attack, they'll drop backwards. So that's kind of helpful in terms of diagnosis. And sometimes the spasms can be super subtle. And so this is why, we'll talk about this a little later, this is why we universally recommend doing video EEG when we diagnose these, because sometimes they're so subtle that if you're not watching in replay on a camera, you're going to miss them. Sometimes kids will cry between the jerks or be upset by them. This is something we're classically taught. I'd say it's probably less common than we're led to believe when we're trained, but they will sometimes become feeling that they appear as though after they have each individual spasm that it upsets them. And then also kids with spasms, there's no rule that says they can't have other seizures. So if a kid has a history of epilepsy, then basically you have to be on high alert and suspicion for spasms potentially happening. So, and then there's another condition that we call West syndrome. That's kind of an older terminology, but a lot of people still use it, which is when an infant has epileptic spasms and then cognitive delay or regression, which is similar to developmental delay, and then a specific EEG finding called hypsarrhythmia. And probably about a third of kids with spasms will have these three things. But the important takeaway of that is also that about 2/3 of kids or more will not have these things and can look different. So some kids can have EEGs that look much more normal than hypsarrhythmia, which I'll show you in a second what hypsarrhythmia looks like. Some kids can present without developmental delay or regression, and some kids will have these findings on the EEG, the regression, but not have the proper spasms that we see until later, because you maybe caught them very early. Okay, so in terms of talking about the epidemiology of spasms, about 3 out of every 10,000 live births in the United States will be affected, which is very similar to the worldwide incidence. It's about equal male to female ratios and a very low probability of having a family history of spasms. They have noted like certain conditions like multiple sclerosis and other things that higher latitudes tend to be more heavily affected, but most people believe this is due to probably a genetic predisposition, but we don't really know. So let's talk EEG for a little bit, because this can be sometimes something that's very challenging to kind of internalize or understand. So we use EEG a lot in epilepsy, and what the EEG, I always tell parents that there's 2 things we generally look for in an EEG. We look for what the brain looks like when it's not having an event or a seizure, and then we look at what the brain looks like when it is having an event or a seizure. So interictal means between seizure, and that's what the brain looks like when it's not seizing. What we look for with spasms is we look for abnormalities of the EEG, and those are things that we typically don't see in kids of the age of the kid who's getting the EEG. So if you have a 6-month-old, we know what a normal 6-month-old EEG looks like. And there's a range of things we can see at 6 months that are considered normal. And we look for things that are not normal in that age group and things that are specific to having infantile spasms. So we've talked a lot about this hypsarrhythmia pattern in spasms, and you'll see that come up all over and over again. So hypsarrhythmia is an interictal pattern that not always, but sometimes is seen with infantile spasms. If a kid has hypsarrhythmia, you're most likely going to see it during their non-REM or non-REM sleep. They can have it when they're awake. They can have it during REM sleep. They can have it whenever they want. But if they have it when they're awake, they're most likely also going to have it during sleep. So that is an important point to remember when you think about the EEG, the type of EEG you do to diagnose spasms. So long ago, some people would do, a 45-minute EEG for a kid with concern for spasms. And if you've ever had an EEG done on a kid under the age of 1, the odds of that kid falling asleep and getting into non-REM sleep in 45 minutes is approaching 0. So we recommend at a minimum to do a video EEG that lasts at least a few hours long. We usually shoot for 4 hours. At our institution at Children's Orange County, we go for an overnight because we absolutely don't want to miss a clue that a kid may be having spasms because it's such a high stakes game. This background we decide, the appearance of these EEG patterns we describe as chaotic, visually chaotic, where it looks like you can't really tell one area of the brain from the next. We say that they're large amplitude or very high voltage, so the waves look much bigger compared to an average kid that age. This is kind of right in the middle there. And then we also can see what we call multifocal independent spikes. And what those are abnormal waveforms that we see in EEG that are very spiky looking and pointed. And I'll show you a picture of this in just a minute. Now, there's also variations on a theme with hypsarrhythmia. So there are certain things we call modified hypsarrhythmia or sometimes evolving hypsarrhythmia. And those can be that you can see other things too. So you can see, instead of having these multifocal spikes, which come from multiple areas of the brain, and they're independent, meaning one area of the brain puts off a spike, then another, and then a different one. You can also have increased synchrony that leads to multiple areas firing at once. So I'll show you a picture of that in just a minute too. You can have another pattern called burst suppression, where there's a burst of activity and then a period of suppression where the EEG gets very flat in between, and that happens over and over again. You can have focality. So a lot of kids that have, let's say, an area of their brain that didn't form correctly when they were being formed in the uterus, will have that area of the brain will generate a lot of abnormal activity that's more focal than the rest of the EEG. And also there's a time factor to consider when you talk about the EEG of spasms. So if you catch a kid with spasms super early, the EEG may not be completely and frankly abnormal. It may look maybe mildly abnormal or even normal. So a lot of times what we'll do if a kid comes in and we're very suspicious that they're having spasms, but the EEG looks normal, is we'll bring them back in a week or two and see if anything's changed. Okay. And then the other thing that we see intra-ictally is if the kid does have a lot of abnormalities, they do tend to go away transiently when the kid actually has a cluster of spasms. So we can kind of look at that. So this is this intra-ictal finding I was talking about. On the left, this is what a normal sleep EEG for an infant looks like. And so up here, above the blue lines, this is the left side of the brain. This is right down the middle of the brain, or the two blue lines. And then everything down here in the black is the right side of the brain. This is the heart, and this is a muscle thing that we measure. So this is normal sleep that we see in a kid this age. These are these things called sleep spindles that are normal things that happened. The waves here are normal, etc. Whereas you can tell there's a very striking difference between that and what we call hypsarrhythmia. So with hypsarrhythmia, you can see the amplitudes are much higher. And I even kind of toned this down a little bit. It's even higher than this, but if you leave it at, full sensitivity, you basically can't see any of these characteristics. So there are things like this that are spikes. See this pointy thing here, there's a pointy thing there, there's a pointy thing here, pointy thing here. See how there's spikes coming from all over? There's one here, trust me, it's kind of obscured, but you can see it. So there's all these spikes and they're occurring independently. So these are the multifocal independent spikes we talked about. And then this pattern kind of obliterates a lot of these normal things that we see. Some of the sleep architecture, like spindles, can be preserved in these kids, but a lot of the normal daytime waveforms we see in a kid this age are basically, kind of obscured by this abnormal activity. So, and then just an example of one of these modified hypsarrhythmia variants that I mentioned earlier. This is a kid who had spasms, who did not get effectively treated for spasms and went on to develop Lennox-Gastaut syndrome, which is a type of epilepsy that usually affects older kids, 3 years and up, and it has a different pattern. But you can see in this last slide here, how we have these multifocal spikes that kind of happen from all these different areas. With this, you can see there's these bigger spikes that synchronize, and they all happen at once all the way across. So this is a kid that hasn't quite made it to Lennox-Gastaut syndrome, but is very concerning because these generalized, these synchronous spikes, which is a form of that modified hypsarrhythmia, just hint to us that this kid is probably going to go on to develop Lennox-Gastaut syndrome, one of the hallmarks of which is what we call a slow spike and wave pattern, which is these big spikes that happen about 1.5 times a second. So you can kind of see that this is kind of evolving to this, and then eventually might make it to Lennox-Gastaut syndrome. Okay, so and now let's talk about what we see on the EEG when a kid has spasms. And this is important because these are the things that we look for that tell us whether it's a spasm or something else. So again, like, just to make things complicated, spasms can look multiple, can look differently depending on the kid, and even in the same kid, they can have different EEG changes with their spasms. But there's certain things we look for. This is probably the most common that we see, is a slow wave that goes across the brain with what's called electrodecremental response, or a flattening of the EEG briefly afterwards. But all these other things can happen too. This is kind of a burst of fast activity with flattening. This is just that this is a spike followed by a slow wave across the brain. This is just flattening. This is kind of a slow wave that's a little sharply contoured. So the point is that the power of doing a video EEG is great because we can combine the video that shows us when the kid moves with the EEG that shows us what the brain's doing to figure out what the likelihood is that these are spasms versus something else. So here's a few examples I put together from some kids. This would be an example of a slow wave. See this big slow wave here, followed by attenuation or electrodecremental response. See how things kind of flatten out for this kind of 1 second interval here, and then kind of these normal waves start coming back. This one's kind of similar, but this maybe has a little bit more of that fast activity. See, big slow wave here, and then it flattens out. There's a little bit of this fast activity, and then these are the normal waves starting to come back, okay? And then this is a kid who just had slow waves. So this kid had more of just one big slow wave here, didn't really have that electrodecremency. It doesn't really get flat like the other one did, and then goes back into kind of their typical background, which their background is a much larger and slower background compared to these two. So it just shows you a little bit of the variability, and it's even more variable than this. But you know, we look for that, and we look for this a consistent EEG change every time the kid has a spasm to try to determine if it's a spasm or not. So, okay, and so what are the different categories we can see that have the possibility of causing spasms? So back in 2010, we had a very a more specific categorization of etiologies. We talk about genetic causes like Down syndrome or trisomy 21. We talk about genetic structural, which is like tuberous sclerosis, which is a genetic disease that causes abnormal brain cells to develop that make you at higher risk for having spasms. There's other structural causes, and sometimes we split these into congenital and acquired. Congenital would be something you're born with, such as like an abnormally formed part of your brain, as opposed to acquired, which is like a stroke or an injury to the brain after birth. There are different metabolic conditions, and a lot of these are genetic as well, that involve ineffective breakdowns of different materials in the body or different chemicals that can build up and cause injuries to your brain cells. And then we also can see some kids that have spasms as a result of their immune system being overactivated, or various infections. But probably about a third of kids, despite all of our technology we have at our disposal, we end up saying, we don't really know exactly why the spasm started. So looking at the relative frequency of those different causes, you can see that having an injury where you're not getting enough oxygen to your brain shortly after birth is a very common cause of spasms, as are chromosomal abnormalities and malformations of development and stroke And then tuberous sclerosis, that condition I mentioned. Those are probably the most common group right here. And then unknown accounts for about a third, like I mentioned. And then these are other more rare conditions that can lead to infantile spasms. So one of the things that's really important to us as epilepsy folks is that we want to make sure people get diagnosed quickly and accurately. So sometimes spasms can be diagnosed inaccurately, meaning that somebody calls something reflux or something like that, and it's not reflux, it's actually spasms. And on the other side of the coin, sometimes people get told their kid has spasms when it's really just reflex. So the video EEG is a great equalizer in this. There's a lot of conditions that can affect kids in the same age as kids with spasms that can mimic infantile spasms. And so we use our testing to figure out exactly what the movements are and to rule out these sorts of things. Okay, and so one of the things we try to encourage our pediatricians in our area about is that if a kid comes in that's the right age, between 3 and 9 months of age, and is having recurrent events that look like spasms, even if you don't think they're spasms, we should evaluate it, because if you miss it or you misdiagnose, it can be a very, very big problem. Okay. So what do we do if we think a kid has spasms? Well, we'll do a continuous video EEG. We'll capture the events that are concerned, and we'll determine if we think that they're spasms or not. If they are, then we typically do some testing to try to figure out why the child has spasms. And that usually starts with an MRI of the brain, as well as genetic testing and metabolic testing. And then we often like to get them plugged in terms of their development, because a lot of these kids will have problems with development. So among the genetic tests we do, the ones that give us the greatest yield are going to be the bigger tests like exome and genome sequencing. These are tests that look at every single element of every gene in your DNA and try to see if there's anything that's been mutated or changed in such a way that it could cause a disease. And really the power of those two tests, the exome and the genome, is comparing the child to the parents, because they look to see if the parents carry any of the same mutations or variants that the child does. And if neither parent has had spasms and the child has a variant in their DNA that neither parent has, in a gene that we know can be related to spasms, then we get highly suspicious that that may be the reason they have spasms. The other two tests are also really important. So the chromosomal microarray is a test that looks at extra or missing copies of DNA, which exome and genome sequencing is not really good at looking at. So I don't want you to think that exome and genome is like the first two plus some. They're complementary tests. So the microarray is usually the first test that we order, as well as an epilepsy gene panel, because we can get that back within the first couple of weeks. And actually, there's a really great program called Behind the Seizure, which is a free genetic testing for children who have new onset seizures. So we'll usually send that right away. That's through a company, Invitae, INVITAE. And then we send the microarray. If those come back normal, we try to get exome sequencing. But sometimes we're limited by insurance, because some insurances don't think it's important to figure out what type of cause you have for your infantile spasms. And so they will not pay for exome sequencing, which still costs on the order of thousands of dollars, which is prohibitive for some of our families. What do you do once you have spasms? Well, we treat it, and we treat it as quickly and effectively as possible. We know that the sooner you start treatment and the sooner you can effectively treat spasms, the better these kids do. The greater their likelihood of not having more seizures, the greater their likelihood of having normal intellect when they're older. And so we start treatment right away. The standard of care at this time is in kids to start one of the first line treatments, which are considered to be either steroids, which include ACTH or prednisolone, and vigabatrin are considered to be the first line treatments for infantile spasms. Most children will be started on steroids. The exception is that when we have kids with tuberous sclerosis, we know that vigabatrin seems to work really well with them, so we often do that. A more recent trend that we've been seeing across the US, especially within the members of our PERC group, is to do what we call dual therapy, which is where you get started on steroids plus vigabatrin at the onset. It's a little bit of a tricky thing because we know the likelihood of the spasms responding to dual therapy is higher than responding to one or the other, but we don't really yet know the long-term outcomes of these kids in terms of any side effects of the dual therapy. We know that the dual therapy is more likely to give you side effects, which just makes sense. But I think it still remains to be proven whether the risk involved with adding 2 medicines instead of 1 is how that balances with the benefit of having a higher likelihood of stopping seizures. So a lot of centers will do something where they'll start with steroids and then they'll evaluate in a week or so. And if the patient's spasms have not stopped, then they'll add the vigabatrin to that. So they'll kind of initiate the dual therapy once the kid has proven that they are not going to respond to the steroids alone. So that's another way of doing it. And then also surgery and the ketogenic diet are on here, not as first-line treatments, but as things to highly consider. Surgery is really important if you have a kid who has a brain that has an area that's been malformed or injured, and the kid does not respond to first-line treatments, because most of the time those areas that are malformed or injured are not contributing to the child's development, to their ability to do things like walking, talking, using their arms, using their legs. But if that area is generating seizures, especially infantile spasms, you may want to consider, operating and removing that area of the brain. There's another surgery that we sometimes do called a corpus callosotomy, where we cut the corpus callosum, which is a structure that connects the left and right sides of the brain. And that can kind of break the network that can generate the infantile spasms. So that can help too. The ketogenic diet is something we typically go to pretty quickly once you fail steroids and vigabatrin. And the downside of it is that it typically takes, in most kids, it takes at least a couple of weeks to start working, maybe even longer. So you don't get that immediate response. So that's something just to keep in mind as well. And then in terms of the treatments, this is some data from the National Infantile Spasms Consortium that came out a few years ago. So the red bar means that the kid had a good response to treatment. The blue bar means that the kid had no response to treatment. Orange means they responded, but a little later. And then relapse is in green. So things to take away from this: when we look at ACTH versus steroids, kids seem to respond immediately more effectively to ACTH than steroids. Kids tend to respond a little later to steroids and ACTH. The relapse rate we feel is higher with steroids and ACTH. And then the non-responder rate is also a little higher with steroids. So, and this is kind of across a very large collection of data from the US that with not standardized treatment regimens. So does this prove to you that steroids are inferior, oral steroids are inferior to ACTH? I don't think it does, but it definitely suggests that ACTH is probably less likely to cause relapse and more likely to work initially, but it's hard to say. Vigabatrin, on the other hand, a response rate similar to steroids, lower than ACTH, and a higher non-responsive rate than either. But a lot of times this is used only in specific instances as the first-line treatment. And then if you use a non-first-line treatment, you can see this is why we really, really, really want people to not use non-first-line treatments, because the odds of not responding are very high and the odds of having a response are very low, and relapse is kind of in there. Okay. So there's all sorts of studies that have looked at this, and the numbers are kind of all over the board, but basically the ACTH is thought to work about 55% of the time, vigabatrin about 35, 36% of the time. And then for an appropriate candidate, surgery may be more effective than these. Like if you have an area of your brain that's malformed and you remove it, that'll be a lot more likely to help you than treating you with ACTH, for instance. But each of these things has side effects. So ACTH or prednisolone are steroids, which can suppress your immune system and make you more likely to get an infection. It can increase your blood pressure, increase your blood sugar, and other things. Vigabatrin, or Sabral's its other name. The main thing we worry about is sedation. And the longer you're on vigabatrin, the greater your likelihood of developing some degree of peripheral vision loss. And Just to be clear, that is vision that is in the periphery, not your central vision. So there's a really nice study by Sean Hussein from up at UCLA that shows that it didn't really affect these kids' ability to see later in life because they're still using their central vision just fine. So we know that this happens, and we kind of monitor it, but it doesn't stop us from using the medicine because the stakes are so high for developmental outcomes. And then, like I said, surgery can be helpful in certain kids, but obviously brain surgery is no simple feat, and you can get deficits from the brain regions and complications that can happen from that surgery. The question of combining your steroid with vigabatrin versus alone, this is out of the UKIS study in 2016 out of the UK, shows that there's a superior likelihood of response to combination therapy. But again, we don't really know the risk, so it's a little hard to kind of weigh that. So this is why a lot of groups are starting to do combo therapy. And then how these kids do long-term. So in terms of their outcomes, about 12% of these kids will pass away by the time they're 6 or 7 years old. And a lot of those kids that do that are very sick in general, or have very bad metabolic conditions, or have very, very bad brain injuries. A lot of kids with spasms, the spasms will spontaneously go away, but if it takes them a while to do so and it's not with treatment, they're often left with cognitive impairment. And then, like I said before, if we treat the spasms and recognize them very quickly, we have a better likelihood of good development and cognitive outcomes, as well as good seizure control and seizure outcomes. Other things that kind of put you in the better prognosis camp would include having a normal MRI, being in the category of an unknown etiology, meaning we never found anything to explain why you have spasms, having an age of onset greater than 4 months of old, because it seems the kids that are more severe present with their spasms younger than that, and then also having no other epilepsy and no developmental delays or regressions prior to the onset of the spasms, as well as a symmetric EEG pattern. So over the long term, 70 to 80% of kids with an unknown cause of spasms will have some degree of intellectual disability. And I think that number is creeping downward now that we're becoming better at recognizing and treating sooner and doing dual therapy. And then intellectual disability to some degree, and it may just be mild or it may be more severe, is present probably in upwards of 90% of those who have a known cause of their spasms. And then basically, if you see hypsarrhythmia on an EEG and you don't have spasms, that also is kind of a bad prognostic indicator. Like I said before, I'll probably say this like 100 times, promptly diagnosing and effectively treating, which is why we don't like to mess around with non-first line treatments, lead to the greatest likelihood of a good outcome. So that was my 10,000-foot view on infantile spasms. So I don't know if anyone has any questions before we talk a little bit about some of the current research going on in spasms. Gianna Moore asks, can traumatic brain injuries cause spasms? Yes, they can. Anything that can cause abnormal brain function can generate spasms. TBI, traumatic brain injury, is a very interesting cause of spasms. I've actually seen kids who have had brain bleed from a TBI develop spasms a couple days after the brain bleed, and then when the surgeons went in and removed the blood clot and the bleed, the spasms went away. So that was, to me, fascinating. But yes, absolutely. Yes, no problem, Jenna. You are welcome. Any other questions before we go ahead with the next stuff? All right, I'm going to stop sharing my screen. I believe Stephanie has a video of another presentation.
I will share that right now.
All right. And then I'll be here hanging out. So after that, is done. If you have more questions, we can talk about it.
Okay. Here we go.
Oh, I can't really hear it. Can anyone else hear this, or is it just me?
Let me do something. Hold on.
Yeah, I can't hear it either.
Okay, hold on 1 second.
It's always very.
Here we go. Here we go.
Talk.
Hold on. Sorry about that. Here we go.
Here we go. Thank you.
So I wanted to thank the organizers of the Epilepsy Awareness Day for inviting me to give a talk today. My name's Daniel Shrey. I'm one of the epilepsy specialists at Children's Orange County, and I'm also the leader of the Infantile Spasms group of the Pediatric Epilepsy Research Consortium, or PERC as it's called. So I wanted to talk to you a little bit today about the work we've been up to over the last 2 years since I started leading the group. And I wanted to go through some of our new and exciting things that hopefully you'll be hearing more about soon. So first, a little bit about PERC. If you aren't too familiar with PERC, PERC's mission statement would be that they aim to provide a network and infrastructure to facilitate collegial, collaborative, practice-changing research to improve the care of children with epilepsy. And how PERC usually functions is just really a way for us all to get together as epilepsy specialists and researchers to do things that would really be impossible to do on our own. So the Spasms group is one of about 15 or so groups in PERC that focuses on a particular disease or a particular problem in epilepsy. And our mission is really to perform impactful research to advance the diagnosis, treatment, and outcomes of children with infantile spasms by leveraging a centralized multi-institutional network to study this rare yet devastating disease. So really our goal is to utilize the infrastructure of PERC and our relationships with each other to do amazing things that we can't do by ourselves. So currently our Spasms group has about 30 different epilepsy centers and foundations involved with the work we're doing, and I've listed them all here. I'm not going to read them to you. But you can see these centers are from all over the United States, from the East Coast, the West Coast, the South, the North, the center of the U.S. And we also partner with the Lennox-Gastaut Syndrome Foundation and the Chan Zuckerberg Foundation too in our work. So right about the time I took over the group in January of 2020, I'm sure you all know that's when we were dealing with probably one of the more severe parts of the COVID-19 pandemic. So although we all had a lot of very exciting research ideas that we wanted to put forth and start working on immediately, we felt it was in our patients' best interest to first build some guidance in terms of how to manage infantile spasms during a pandemic. So we quickly got together as a group and we authored a couple of publications that go over how we should treat and evaluate and diagnose our patients who may have spasms during a pandemic. And these really focused upon trying to minimize the patient's exposure to other people who may be infected with COVID, try to keeping them out of the hospital and out of the ER as much as possible, and how to safely treat and reevaluate them after we've diagnosed them with spasms. So these two articles came out and were quickly adopted by the Child Neurology Society and other groups as the current practice during COVID of how to manage kids with spasms. After that, we started to look back at a previous data set that was collected prior to 2020, and this was the National Infantile Spasms Consortium database. This database was a prospective study of the evaluation, diagnosis, and treatment of spasms in the United States, and they collected several hundred patients worth of information about how we're treating and diagnosing and following up on these kids. This study is remarkable work that has led to a lot of different publications and kind of practice-changing knowledge. And we felt inclined to continue to look at this amazing database and try to see what other information we could learn from it. So we have two ongoing projects that are pretty far along looking at this database. The first is a project that's headed by Chris Euskaitis at Boston Children's, and we call that the Time to Treat or the Time to Test project. And this project looks at kids with spasms when they're first treated and tries to determine how long we would need to have them on that treatment before we know whether or not that treatment's going to work. And then we would like to use that information to know when we should start a new treatment if the first treatment doesn't work. Most centers right now are waiting about 2 weeks after starting the first treatment before they reevaluate with an EEG or a clinical update and consider another treatment. And some of the information we're finding from the NISC database tells us that we may be able to reevaluate sooner than that. We really want to be able to effectively treat and stop spasms as soon as possible. So we want to know what the shortest amount of time is from when the treatment started until we need to reevaluate and consider a second treatment if the first one's not working. So that project's been going very well. We've had a couple abstracts presented at the Child Neurology Society meeting and elsewhere, and there's probably going to be a manuscript or paper coming out of that sometime in the next few months. The second project that's looking back into the NISC database is focusing on disparities in treatment of children with infantile spasms. So this is looking across all these several hundred kids in the United States and considering things like their racial and ethnic backgrounds, whether they live in a more urban or rural setting, and looking to see if they're all receiving the same quality of care in terms of diagnosis of their spasms and treatment of their spasms. And we're finding some very interesting characteristics of patients that seem to lend themselves to receiving not the highest quality of care for spasms. And for us as clinicians, this is very, very important work because it teaches us how we can be better at providing very equal care among all children with spasms and how we can especially help those who are getting disparate care. So this, again, similar to the other study, this study has already produced some really great work in abstracts, and a manuscript is currently being worked on for this that we're hoping comes out in the next couple of months. So I want to take the rest of the time basically and talk about our really big, exciting project we're doing. So this project is called a multimodal biomarker-based predictive model for infantile spasms, which is a lot of words. But what it is basically is we realized within our spasms group that a lot of us had very specific expertise within spasms. Some of us really liked EEGs. Some of us liked doing computational analysis and modeling. Some of us really focused on MRIs and imaging. Some of us use machine learning methods to try to learn about diseases. Some of us use logistical modeling to learn about diseases. So we said, you know what, no one's ever put all of these tools and all of these types of data together and really tried to figure out how to predict how kids are going to do and which kids are going to respond to treatment and which kids aren't in infantile spasms. So this has been something we've kind of been putting together and working on since I started leading the group back in 2020. And I'm very excited to say that we were just awarded a grant by the Pediatric Epilepsy Research Foundation to build the infrastructure and lay the groundwork for doing this work. So this work is not possible without this incredibly broad and sizable group of institutions and foundations that are supporting it. I had a lot of trouble fitting these all on one slide, but I did my best. So you can see that these are a lot of the same groups that are part of our infantile spasms interest group, and we have a total of 17 centers plus a couple alternates that are part of this project. It's just been amazing because ever since that we found out we were going to be funded for the work, the amount of work that's gone into getting all these groups together, building the infrastructure for which we partnered with Amazon Web Services, and getting everybody to pull their data is just such a huge amount of work, but such an important thing for us to do. We're looking to collect at least 400 patients worth of data over the course of a year, which is a pretty ambitious goal, but I believe we can do it. And so we're all working together to make this happen. So a little bit about exactly what we want to do with this study. So this is kind of our basic knowledge of how we treat and how we measure treatment response in infantile spasms. So when a child first comes in and we think they have infantile spasms, we do some testing to figure out if they have spasms or not, and that's the diagnostic phase of the workup. So we'll do an EEG, we may do an MRI, we may do some blood or urine or other sorts of tests. And then if they are diagnosed with spasms, we usually try to start treatment right away because we know that the longer the treatment of spasms is delayed, the worse the outcome is going to be. So when we first have these new onset spasms patients, we'll start a treatment. And then, like I said before, we kind of wait about 2 weeks before we measure whether that treatment worked or not. Now we know, based on the NISC database and other large databases that have looked at infantile spasms, that about 2/3 or so of children will respond to that first treatment, meaning that their spasms will stop and their EEG will no longer show this pattern called hypsarrhythmia. And then about 1/3 or so, 27 to 45% of new onset spasms patients will not respond to the initial treatment. So the first question we want to ask as part of our research is there any way for us to know, even before we start treatment, which of these kids are going to respond and which ones aren't? Because that would allow us to stratify the patients. And what that means is if we had a kid and we could look at these EEG and MRI biomarkers and we said, oh, you know what, this kid is high risk for non-response, maybe that's a kid we would treat more aggressively. Maybe instead of putting them on one medication like steroids, we would add a second medicine like vigabatrin or something else, or we would start the ketogenic diet, who knows. And then, so that's the first question. Can we predict responders and non-responders based on what we see when the kid first comes in, or based on what we see during the first few days of treatment? And then, as you can see, if you do respond to treatment, that's fantastic, although you're not out of the woods yet, because among those who respond to treatment by 2 weeks, about 2/3 of them will continue to stay in remission and not have relapse of their spasms, but a solid third of those patients will have spasms come back. And so there's a lot of questions that are unanswered about spasms relapse, and those would include exactly how to monitor the kids that you think are at high risk for relapse, which kids are high risk for relapse, and is there any way to predict those who will stay in remission versus relapse either at the time of diagnosis or at the 2-week mark when you're measuring their response. And so this is the predictive biomarker model we're building. We want to predict initial response at 2 weeks out, and we also want to see, using the information we have at the time of diagnosis and at the 2-week mark, whether we can predict remission and relapse. Because we think if we can do that somewhat accurately, that'll really help us treat these kids better. It'll help us to be more aggressive with the kids that need more aggressive treatment. It'll help us to not be so aggressive in the kids who don't need as aggressive treatment. And it will help us to know if we need to consider other non-medical or non-medicinal interventions, such as surgery or the ketogenic diet or some other or its stimulators like the vagus nerve stimulator, a deep brain stimulator to treat these kids. Because a lot of these new technologies and surgical procedures, we really believe are going to be game-changing in how we manage spasms. So what we're doing in terms of looking at these multimodal data is, multimodal means different types of data. So when we look at a kid with spasms, we do a lot of different testing and we collect a lot of information. So we collect EEG information, and those are brain waves that we record from the scalp. We, a lot of times, will get an MRI, which is a picture of the structure of the brain and the different pathways inside the brain. And then we also collect what we call clinical data, which is there a family history of epilepsy? Did the kid have a birth trauma? Is there any genetic testing that's been done that suggests why the kid develops spasms? So those are the multimodal different types of data that we can see within kids with spasms. And then what we're planning to do is to leverage multiple different techniques of analyzing that data to figure out if there's anything in that data that helps us to predict how these kids do. And a couple of the methods we're going to be using include what we call machine learning. And machine learning is a technique whereby we look at a large set of data and we use different computational algorithms to allow the computer model to figure out exactly what is important in that data and what's not. And we allow that computer model then to build a predictive model of how these kids do. And then once we've done that, we can go and we can do a second study where we collect new data. We can test that model and see if it still works on a completely different data set. We also are going to leverage a technique that's called computational analysis. And this is a way to look at either EEG or MRI data. And what this is using computer code and computer software to analyze EEG and MRI and to measure things that we as humans aren't really good at seeing with our naked eye, right? So as an epilepsy specialist, I look at EEGs and MRIs all the time. I'm trained to recognize certain patterns in the EEG, certain findings in the MRI, but there's certain things a computer can pick up on that I can't, like subtle differences between the left and right side of the brain, differences in the volume of different brain structures. Those things would be very challenging for a human to pick up if they're not strikingly different. But in terms of a computational analysis to pick those up, that's basically what computational analysis is very good at. So we're going to combine that with the clinical interpretation of these findings too. And we're going to look at everything together and figure out, can we find a way to predict how these kids do? So the other big part of this project and a big thrust of the work is to build just the infrastructure to do this. And what I mean by infrastructure is that we have 17 different centers spread all across the country that are all collecting different data types from multiple different types of electronic medical records, imaging systems, EEG recording software. So we have to get all that data into the same format. We have to put it all in one place. We have to remove all the identifying information from it so that, so that we don't have any breach of privacy or confidentiality or anything. And then we have to be able to analyze it. And historically, the way people have analyzed large data sets like this is once they collect them, one center will go in and they'll clean it all up, and then they'll host it somewhere, or they'll download it at each individual center, and each individual center will do their analysis on computers at their own institution. But we're really looking forward and trying to be more visionary with this. So we're partnering with Amazon Web Services to build a cloud-based ecosystem that allows everyone to upload their data to the cloud. We want to build some autonomous tools that can take that data and process it and make it standardized, remove the patient information from it. And then we want our investigators to be able to log into that same system and do their analysis in the cloud, meaning they don't have to download this enormous data set to a computer. All the software they need, all the code they need is in the cloud, and they can just run it there. And that way they can post their results in the cloud. Other people can utilize their code as well. And this really would facilitate the more collaborative environment we're going for. So that's one thing that we're really excited about this project, is we can build this infrastructure that then can be used not only for other work in our group with spasms, but for any of the other PERT groups too that focus on other diseases that kids have. So that's all I wanted to say about our big project that we've been working on. Stay tuned for that. We just launched it September 1st, so we're excited about it, and we believe that we can probably get some good results within the next year or two out of that project. And I wanted to mention just a couple other studies that we have that are ongoing. So one of the things that we're very passionate about in the spasms group is trying to find new things we can do to help kids with spasms who don't respond to standard treatment. So if the kid doesn't respond to medication or the ketogenic diet, what is the best option? Is the best option surgery? Is the best option a stimulator like a deep brain stimulator or a vagus nerve stimulator? So a lot of these things we don't really know yet. So we're starting to frame out some new studies to look at whether different surgeries may help with refractory infantile spasms, such as a corpus callosotomy. So that's a type of surgery where the connection between the right and left hemisphere, called the corpus callosum, is severed surgically, either with a laser or with a cautery knife. And those surgeries can separate the two hemispheres and inhibit the spread of epileptic activity from one hemisphere to the other, and sometimes that can stop spasms. We don't really have a large data set yet to look at, or a large study that shows how well this works. We have some medium-sized studies that have been kind of helpful, and they've been very promising. So we want to start to look at this on a larger scale among the 30 centers that are part of our group. The other thing we want to look at is we actually want to go back again to that NISC data set, and we want to look at that data set and this new one we gather from the PERF project and determine how good we are at doing the same thing after a kid fails the first medicine. So if you start a kid on a steroid when they get diagnosed with spasms and they don't respond, do we all do everything the same from there on out, or are we all very variable in the way we treat them? And from what we know, there is a lot of variability, and it's a little bit of dealer's choice in terms of which medicines come next, how quickly the follow-up happens. So we want to look at how variable that is and maybe try to standardize that so we can provide the same level of care among all institutions regardless of where we are. So those are two studies that are kind of ongoing that we're excited to hopefully get off the ground within the next year or two. So I want to thank you guys for tuning in, and I wanted to thank you for the opportunity to tell you about all the cool stuff we're doing with the Spasms group. And I would encourage you to stay tuned for what comes out of this group in the next couple of years, because I think we're going to find some really interesting stuff that's going to change the way we take care of kids with spasms. So thanks.
All right, any questions about the first talk or the video?
I'm still absorbing everything. It's quite amazing and spectacular. So thank you for doing all of that work on behalf of the families in Orange County and beyond, since it's quite a large project.
Oh, you're welcome. Yeah, it's a lot of work, but it's very exciting. And so we're hopeful that we can kind of find new things that change the way we take care of this condition to help these kids. So
Also, ESNOC, we just applied for a grant to address disparity in epilepsy care in conjunction with developmental and intellectual disability. And if we do get the grant, then we should discuss collaborating and see if there are areas we can work together.
yeah, no, that's actually something we're addressing in the new project. We're collecting information regarding primary language for the patients and their families, and what language is spoken at home and whether an interpreter is needed for medical discussions. Because in the NISC study, and Jen, just remind me sometime and I'll send you the abstracts that are being written, and there's a paper in progress about this. We're finding that there is some signal that folks that are not primarily English speaking are at higher risk for receiving suboptimal care for spasms. And so this is something we're addressing in the current study that we're designing, as well as the one that's going to come next.
Okay, I will send you an email to remind you. Thank you.
I can't promise you I'll get to your email today. I'll get to it as soon as I can.
Absolutely no pressure.
Okay, well, 1 minute to spare. It seems like if anyone else has questions, they can throw them in the chat, or they could say them now. I have to hop over to the PERC presentation Zoom because we're giving talks there next. So if you missed the second half of the talk with the video, that's going to be I think I'm going to rebroadcast that in the PERC Zoom this afternoon in about, I think it's like in an hour or so. Let me take a look. It'll be at PERC talks start now, but mine is around in about an hour at 12:05 Pacific.
Thank you. I know Kathy will want to see that one too.
Absolutely.
Thank you, Dr. Shrey.
All right. Take care, everyone.